The challenge. What is a differential diagnosis? Well, we have to recognize that a differential diagnosis is made out of a grouping of symptoms. And we know that an inflammatory process on the skin typically is red, warm, it may blanch, but that doesn't always mean that it's an inflammatory process. It can be other processes that are causing that particular reaction. So we need to recognize what that collection of signs and symptoms may potentially mean. Also, recall basic pathophysiology, restate in terms of disease, and reconnect with the initial complaint. So it's a full circle type of a process in diagnosing our patients. A lot of diagnostic errors occur because we try to fit the data that our hypothesis gives us rather than fitting the hypothesis into the data. So it's important not to draw your conclusions too quickly. So a patient may come in and you say to yourself, well, patient has a sore throat, patient has a fever, patient's breath smells like strep, must be strep. But perhaps it isn't strep. Perhaps it's a peritonsillar abscess. So don't commit yourself to one diagnosis too soon. I had a patient today. Now I know that the majority of symptoms when you're dealing with strep throat, it is headache, fever, stomachache, sore throat. The patient can present with one or all four of those symptoms. However, when a patient presents with sore throat, cough, and congestion, it typically isn't strep throat. That's what the literature supports. But it doesn't always translate that way in practice. If the patient comes in and presents with typical flu symptoms, fever, body aches, cough, sore throat, sometimes it can be strep, as I had today. I had a patient that came in, looked like the flu, did a flu test was negative, and I had become so consumed with the fact that he was presenting with so many flu-like symptoms that I hadn't asked how intense his sore throat pain was. When I asked that question, the throat pain is quite bad. It's difficult to swallow. I decided to do a strep test, and indeed it was positive. So that's a simple example to show you, but that translates into more complicated cases also. We're going to go over a few made-up cases of patients, and sorry about that. I had some background noise. Our first patient is an obese Caucasian male with a history of hypertension and smoking, complains of severe lower back pain, has lasted for 4 days. The back pain is accompanied by occasional vomiting that radiates intermittently to both lower quadrants of the abdomen. The increased severity of back pain has awoken him. On the morning he sees his physician. Vital signs are normal except a mild elevation of the systolic blood pressure. The assessment of the patient finds no significant physical abnormalities. Femoral pulses are strong and symmetrical. A flat plate X-ray of the abdomen is read and later confirmed as normal, and the CBC is normal. Preliminary diagnosis is musculoskeletal back pain, and narcotic analgesics were administered. At the shift change, the patient's care is transferred to a different nurse provider, who reviews the patient and agrees with the previous diagnostic impression. That NP subsequently discharges the patient with a prescription for analgesics and the instruction to find a family doctor for follow-up care. Outcome. 2 days later, the patient was found dead at home. An autopsy revealed the patient had a ruptured abdominal aortic aneurysm with 3,000 cc's of blood in the retroperitoneal space. The patient's family threatens a legal action, alleging failure to diagnose the condition and failure to provide adequate discharge instructions. So don't always go for the easy fix. I try to tell providers that it sometimes is helpful to think of the worst first and then talk your way out of it. Lessons learned from this particular case: a leaking AAA can mimic renal colic, mechanical back pain, and diverticulitis or gastritis. In particular, AAA might be considered in the differential diagnosis of an older patient with symptoms suggestive of renal colic. Severe radiating pain is a common symptom, and syncope and vomiting can also be associated with AAA. A patient with persistent symptoms may warrant a new evaluation as appropriate. Alternative diagnoses include the worst case possibility that should be considered, as I stated earlier. So, because the test came back normal, the x-ray came back normal, the patient was discharged home, even though the patient was still suffering symptoms. That's not a great practice to adopt. The patient had pain that required analgesia. So even if appropriate doses of narcotics control that pain, it's still prudent to review the patient to determine if the diagnosis is being masked by the analgesia. The medical record should indicate that the diagnosis with the worst prognosis, in this particular case, a AAA, was considered and was pursued if reasonable action was noted to do so. So the rationale for not investigating should also be clearly documented, because if you look back at the earlier slide, it clearly states that all of the findings had been normal. However, the symptoms still persisted. The presence of a certain red flag. These findings may prompt experienced physicians or healthcare providers to accept or rule in a serious specific diagnosis, yet even experienced healthcare providers are often surprised by the range of the symptoms and signs of the diseases. So as new healthcare providers, again, you're going to be going from being an expert in the field that you currently are practicing in, and once again going into the realm of being a novice. And it's a very difficult and task, and quite a humbling task. So in doing this transition, make sure that you have a good support person or a good support group so that you can sound off. That's one of the reasons it's nice for new grad NPs to have a mentor, whether it be a nurse practitioner, another nurse practitioner, or their collaborating physician, that they can sound off things on, because you are entering a new realm. History taking and data collection. In a legal action, peer experts will be critical if insufficient information has been obtained from the patient. So, taking an adequate history of the patient's health condition provides the patient with an opportunity to express his or her current health concerns. It's nice to ask the patient, what are your concerns? What do you think it could be? We're not asking them to diagnose themselves, but sometimes patients come in with a certain something in their head that they convince themselves they have, whether from WebMD or some other internet source. And as healthcare providers, it actually will help us to either state, well, you know what, no, the evidence doesn't support that you have that, or it actually can be one of those clues that may give us the opportunity to investigate further. If the patient's unable to provide history due to language barrier, capacity issues, that's not a good enough reason to not have an adequate history. We have many resources out there now, whether it be a telephone line or interpreters in the facility that you work for, or a Skyping service. There are many services that can be provided, and it is our obligation, legal obligation as healthcare providers, to be able to provide our clients with the ability to communicate with us. Have you adequately assessed any relevant risk factors, including family history, which may help in the diagnosis? Another very important factor, this becomes a troubling thing when you have a patient that doesn't know their family history due to adoption or estranged family dynamics. But family history can help. Certain things run in families, and it may actually help you narrow down your differential list. Are there any red flag symptoms? Numbness, tingling, flashing lights. All of those things that would make you say, this is an emergency situation. Have you determined what the patient's already done to manage her symptoms or his symptoms? I always ask my patients, have you been taking any medications or doing anything to try and help make these symptoms better? And when they respond, then you have to ask them, is there any improvement? Does it help at all? Now I'm going to skip the next one because telephone triage is never a good idea, and I suggest you avoid it. Read notes from other healthcare professionals. I do telephone follow-up phone calls on patients, and I always review the notes of the provider that had taken care of the patient prior. Basically it's those phone calls a couple of days after the visit, and I say, hi, I'm calling to see how you're feeling, if you're feeling better or if there's been any change in your condition since you were seen by the nurse practitioner. So I always review those notes to see what had happened. And pertinent medical records, test results, and consultation reports available. And have they been noted? This is something that needs to be kept up on. Right now, well, actually, a few years ago, I can't guarantee that it is now, but a few years ago, the case that was being seen in malpractice court most often was failure to communicate to the patient that they had had an abnormal mammogram. And think about it. You go to your doctor for your annual exam. You get a prescription for a mammogram. You go, you get your mammogram, and you don't hear anything. Well, you think, oh, well, no news is good news. And you take a sigh and you're relieved, and that's it. But that's not the case. If at any time that happens, as a patient, you always need to follow up with the healthcare provider. You don't know if there's been a miscommunication, the results didn't get faxed, or they were faxed and misplaced. But you need to have a good system in place to follow up on any lab work, x-rays, mammograms, CT scans, anything that's been done on your patient. There needs to be a good system in place to verify that those test results have been reviewed, that the patient has been notified, and that any action that needs to be taken is taken. Huge liability. The physical examination. In legal action, peer experts will be critical if they consider the physical examination to have been cursory, given the patient's symptoms. So did you perform an appropriate physical examination? If the review of systems, which is that complaint list that the patient comes in with, if the patient has a runny nose, congestion, cough, you have to make sure that all of those areas have been examined and documented that they've been examined. Even though the likelihood of there being something wrong in their neurologic system, you still have to make that determination and document that their neurologic system is intact if they're complaining of headache, dizziness, or things of that nature. It's necessary to take vital signs, and have you accounted for any abnormalities? Patients coming in with colds with elevated blood pressures, I'll ask them, have you been taking any decongestants? If they've been taking decongestants, I'll make a notation of that, take the blood pressure again if it continues to be elevated. I will make the diagnosis, an added diagnosis, not the primary diagnosis, but a secondary diagnosis, hypertension, elevated blood pressure without a diagnosis of hypertension. There actually is a code that states that. and I'll make a notation that the patient has been taking decongestants for symptoms. Have you assessed the patient appropriately for the clinical complaint? And again, this is what I discussed earlier. If the patient's coming in with nausea, vomiting, diarrhea, and you haven't made a notation that you examined the abdomen, and then they end up with a ruptured appendix, you may be legally liable for that. To avoid misunderstandings, explain the reasons for the physical examination, especially if you have to look at the genitalia. And nowadays, it's not a bad idea to have a chaperone present for intimate procedures. So now we're going to talk a little bit more about the differential diagnosis. This is a list of possible conditions that might produce you might produce from looking at the patient's symptoms and signs, and it's a very important part of your clinical reasoning. If a serious diagnosis comes to your mind based on the symptoms, have you considered the likelihood of it or whether it needs to be ruled out by testing or referral? Now, in my practice, if a patient comes in, for example, with suspected peritonsillar abscess, which is one tonsil greatly larger than the other, you may have uvula deviation, that's considered a medical emergency, and that patient has to go to the emergency room. So you need to consider whether or not the patient you're taking care of is actually in your scope of practice. Many serious disorders are challenging to diagnose, and remember what we've been saying throughout this whole thing, this whole presentation, is ruling out worst case scenario. Now, this presentation formulating a diagnosis. Don't rely on the classic features of a disease because that can be misleading. Disease characteristics change and vary, and symptoms can change by the minute or the hour. Look to see if you have sufficient understanding of the clinical presentation and able to offer an opinion of the diagnosis. What else could it be? That's the crux of it. When you're looking at all of those clues that you have, everything that you have heard, seen, felt, looked at, heard, what could it be? If the patient returns with persistent symptoms or fails to respond to the therapies as expected, you've got to start all over again, or perhaps refer. So if the patient has persistent sinusitis, which is not being managed by your treatment, yeah, you know what? I think you need to be followed up by ENT. You get a youngster that's got 4 or 5 strep throats in a 12-month period, I think you need to be followed by ENT. Have you considered using diagnostic decision support tools like Hippocrates or UpToDate? There are so many apps out there right now that can be very helpful in determining your differential diagnosis. Hihowever, they don't come without a cost. UpToDate is a phenomenal program. I love it, but it costs in excess of $500 a year. Hippocrates is a little more affordable. I think it's about $100 a year, and I do have that on my smartphone. However, you'd be surprised how many facilities that you'll be working with actually have these on their computer systems, because they know it's in their best it's in their best it's for the best for them to actually have these systems in place there. It looks good if anything ever went to court. And follow your gut. Are you distressed by the patient's condition or behavior? I think that our best instincts are better than anything, even these expensive diagnostic tools. So if your gut is telling you that there's something going on with this patient and you just can't put your finger on it, then you need to step it up and either refer or get a consult on this patient. Ordering investigations. So when deciding whether to use an available healthcare resource, act in the patient's best interest. So you don't want to order a whole bunch of tests that the patient's going to be responsible to pay for if it's not necessary. So please be judicious with ordering tests on patients, especially if they don't have any insurance, because those out-of-pocket costs can be phenomenal. And as nurse practitioners, I think it's important for us to keep that in mind when we're caring for our patients. Always stay up to date with the clinical practice guidelines. Every year, at least, you should be reviewing from CDC what the standards are. And just make sure that you are discussing these alternatives with the patient. So you don't want to just come in there and say, I'm going to send you to the emergency room because I think you've got a peritonsillar abscess and it's a medical emergency. Throughout the visit, as soon as you get some of those red flags, keep an open communication with the patient so that they're not terrified when you come at them with something like that. And let's see. Make sure that all of the important information is included in any requisition forms. So if I have a patient that comes in with a positive TB test, I want the patient to have a chest x-ray to rule it out. That's got to be written on the prescription or the lab request. It has to be written. You just chest x-ray, A&P views, positive tuberculosis test, skin test, rule out active TB. So that when the radiologist reads that, they'll make a notation of that in the report. With our female population, must know if they're pregnant or not. And not only could the pregnancy be causing their symptoms, they could have abdominal pain, could be a potential ectopic pregnancy. And also, if I'm going to be prescribing any medication, I have to prescribe a medication that is within their range. You wouldn't be prescribing category C or D drugs on a pregnant woman. In addition, some nurse practitioners in the contracts that they have can't take care of pregnant women, so important to know those things. Here we have another investigative case that I found. I believe I found this one. This presentation is like a grandfather quilt of references that I found on the internet. So none of this is my own making. This is a conglomeration of different stuff that I found, so I take no credit for it. I give full credit to the wonderful people who were smart enough to come up with these great cases. So on this particular patient, we have a 55-year-old woman coming in for a screening mammogram. Radiologist dictates the report as a lesion in the left upper quadrant, suspicious for malignancy, recommends a needle biopsy. The report's transcribed but not sent to the referring physician. And as I had stated prior, patient assumes no news is good news, does no follow-up. Radiologist assumes the report's been sent to the family physician. 1 year later, the patient presents to her family physician with a palpable lump. Biopsy confirms invasive carcinoma with now lymph node involvement. Not only has this generated a legal liability, but what about the moral and ethical responsibility of the providers? This patient now potentially has a death sentence when a year ago it may have just been a simple lumpectomy. And that's just an explanation of what I said. Here's another case. A 34-year-old or 35-year-old white woman presents with a recurrent crampy abdominal pain that's been occurring over the past several years. It's getting increasingly severe, usually relieved by a bowel movement, intermittent constipation, and loose stools, denies blood in the stool. The pain tends to be diffuse in nature and seems unrelated to diet, exercise, or stress. So she's new to your practice, having just recently moved here. Her CC is, I want to find out what's wrong. I'm tired of always worrying about where a bathroom is. So that chief complaint is quite clear. She wants to get to the bottom of this and find out what's going on. The physical examination reveals an essentially normal abdominal exam and overall negative general exam. The stool is negative for blood and mucus. The patient's of normal height and weight, doesn't smoke, only drinks socially and has a good job, denies excessive stress, married without children, no recent weight loss. So what additional data do you think we need from this patient? I want you to think about this in your head. What, if any, laboratory tests do you need and why? What's your list of working diagnoses, and how do you rule out each one? What plan of care would you devise for this patient? What follow-up is needed? What patient education is important? And what complementary therapies might be helpful for this patient? Now, I have a couple of things that roll around in my head. Well, I want to rule out, differential diagnosis. I could go right from really bad ones. Ovarian cancer, colon cancer. I also am thinking of some other stuff like irritable bowel, Crohn's. This is an easy patient for me to come up with differential diagnoses. I could come up with a zillion of them on her. An 18-year-old woman presents with a new onset abdominal pain and nausea, vomiting over the past 18 hours. She's accompanied by her mother. She's tearful and in distress. The patient's not new to your practice. You've been following her for many years. And her chief complaint is the pain is getting worse. Physical exam. Let's see. She's got a low-grade temp. Rasps are up a little tiny bit. She's guarding. She looks as though she's in acute distress. The pain is periumbilical. Some right lower quadrant tenderness with rebound, denies pregnancy, denies sexual contact. Okay, I'm looking at these. First of all, the fact that she denies pregnancy and denies sexual contact means nothing to me. I'm going to assume that she's pregnant with a potential tubal pregnancy, or she could have an appendicitis. So those are two easy ones that I can think of. So what other data do you need to diagnose the patient? Would you do a gynae exam? Absolutely. What laboratory tests are important and why? I want an ultrasound. I want a CBC. I want a CT of the area to see if it's the appendix. And do I need a surgical consult? Absolutely. So how many patients diagnosed with appendicitis in actuality have the condition at the time of surgery when the appendix is directly visualized? What are the potential complications? And what's the plan? Well, we know that if we don't act fast enough, we can end up with a ruptured appendix and potential peritonitis. Or we can have a ruptured tube and a patient that exsanguinates within minutes. So this, to me, sounds like a medical emergency. Here's another one. A 45-year-old man presents with 3 days of rectal bleeding. The blood's bright red, and he has seen it on his stool as well as tissue. There's some pain associated with the passing of his stool, which has been hard. This patient has been in the practice for a long time, but we haven't seen him in a long time. He did not see any need to come in because he was feeling okay. Now, look at his chief complaint. Do I have cancer? Well, we know right there, red flag, he's concerned. Perhaps he has a family history. People who have a strong familial tendency to develop colon cancer will sometimes develop it in the 40s. So if there's a strong family history of colon cancer, the first colonoscopy should be done at 40. Perhaps he hasn't done that. So let me think about my differential. On my differential, I have colon cancer and rectal cancer. I have hemorrhoids. I have a fissure. And what other ones can you come up with? Normally I'm doing this lecture in class, so it's a great opportunity for us to have some open communication, and we can come up with quite a list of differential diagnoses on this particular patient. Let's see. Vital signs on this patient look normal. Abdominal exam is negative. No family history of colon cancer. No history of bleeding before this episode. There is a somewhat painful stool is positive for blood. Okay. So here's some questions to think about in your head. How do you distinguish between a straightforward case of hemorrhoids versus potentially life-threatening colon cancer and GI bleeding? So what things in the history are important to establish? What's your plan of care, and what complementary therapies would be appropriate? Well, what I'm going to tell this patient is we're going to examine him to find out what's going on. That although colon cancer is a possibility, it's unlikely because it's bright red blood. More than likely, this bright red bleeding is caused by his constipation, and talk to him like this. I would do an examination to see if there are any hemorrhoids internally or externally. I would increase fiber and fluids in his diet, and this is a patient going for a GI consult.